For hundreds of thousands of people, it's not just a treatment. It's literally the only thing keeping them alive. It's a marvel of modern medicine. But what happens when that very lifeline starts to break down? Today, we're going to look inside the critical and often fragile connection at the very heart of dialysis.
You know, hemodialysis is really one of those modern medical miracles. It's an incredible engineering solution that stands between a patient and what would otherwise be a fatal disease. For the people who depend on it, this isn't just some abstract medical procedure, it is their entire world.
Okay, so at the very center of this whole process is something called vascular access. Now, the easiest way to think about it is like a super high-performance port, a bioengineered connection that links a patient's body to the dialysis machine. It's the physical bridge that makes the entire life-saving process even possible.
But here's the crazy part, right? This absolutely essential connection, this lifeline, is often the most fragile piece of the entire system. So, you gotta ask, why? Why is this crucial component so prone to failure? That's what we're here to unpack.
And this brings us right to what's known in the field as the dialysis access conundrum, a really complex problem with some serious consequences, both for patients and for the healthcare system as a whole. Let's start with the money, because that always tells a story. A staggering 20%. I mean, think about that. 1/5 of the entire cost of dialysis care is spent just fixing problems with this one connection point. That's a huge financial drain coming from a single recurring point of failure. And listen, the costs are not just financial. These access problems are a main reason dialysis patients end up back in the hospital, and they're a huge factor in poor health outcomes and even death. It's a messy problem, you know? It involves surgeons, nephrologists, radiologists, all coming at it from different angles with different tools and experience levels, which just adds layers of complexity. So, at the end of the day, the real issue isn't about which type of doctor is best or whose turf this is. It's about building a system that delivers high-quality, consistent results for every patient, every single time. The focus has to shift from professional territory to patient outcomes, period. That search for consistency, for quality, led to a really innovative solution, the Dialysis Access Center, or DAC for short. The core idea is actually pretty simple. Take this highly specialized care out of the chaotic one-size-fits-all hospital environment and put it in a focused, dedicated setting. So put simply, a DAC is like a one-stop shop for dialysis patients. It's an outpatient clinic built from the ground up with just one purpose: to create, maintain, and repair vascular access points as efficiently and effectively as possible. So what makes the DAC model so special? Well, first, they're convenient. They're not buried deep inside some giant hospital maze. Everything about them is specialized: the equipment, the staff, the whole shebang. They also work hand in glove with the dialysis clinics for seamless coordination. And crucially, because they see the same patients over and over, they develop a personal connection and a true team approach to care.
Okay, so that's the concept. But what makes these centers actually work so well in the real world? Well, it all comes down to a few key ingredients.
It all starts with a patient-first philosophy. I mean, the entire environment is designed for them, from making parking easy all the way to the recovery rooms. The procedure rooms themselves are streamlined for one job and one job only, which just boosts efficiency. And the entire process is built for speed, which is absolutely critical for patients on a tight dialysis schedule.
But really, the most critical ingredient of all is the team. Everyone who works there is an expert in one thing: caring for dialysis patients. They really function like a Formula One pit crew: fast, seamless, perfectly coordinated. Because they know that for these patients, every single minute counts. So we have this specialized model and a dedicated team. That all sounds great, but does it actually produce better results? Well, the data provides a pretty clear and compelling answer to that.
So let's put the two models head-to-head. In one corner, we have the specialized standalone dialysis access center, the DAC, and in the other, the traditional hospital outpatient department, or HOPD.
And wow, the results are striking. Across the board, patients treated in DACs just do better. They have fewer infections, fewer hospitalizations, and, here's the big one, a significantly lower mortality rate. And on top of all that, the cost of care is actually lower. Better outcomes at a lower cost, that's the holy grail in healthcare.
But let's just focus on the single most important metric of all: survival.
The data shows that a patient treated in a DAC has a statistically significant lower chance of dying compared to one in a traditional hospital setting. We're talking a difference of nearly 6 percentage points. That gap, that translates into thousands of lives.
You know, the researchers who studied all this put it very plainly. When it comes to dialysis access care, the DAC model just appears superior in every key area: safety, clinical outcomes, and the patient experience.
So we have a proven better model of care. The story should end there, right? Case closed. Well, unfortunately, this successful innovation is now facing a serious threat, not from medical competition, but from economic policy.
You see, for over a decade, the reimbursement rates, the amount these centers get paid for what they do, have been on a steady decline. Then, after a really sharp cut in 2017, the financial model that allows these centers to even exist has been pushed right to the breaking point. And what's the direct result of this financial squeeze? Since those deep cuts in 2017, more than a quarter of these highly effective access centers have been forced to shut their doors for good. A proven solution is literally disappearing just because it's no longer financially viable to keep it running. And this leaves us at a really critical juncture. We have a model that saves lives, improves patient satisfaction, and lowers overall costs, yet it is fighting for its own survival. This is the core conflict. Right here, the evidence is just undeniable. The DAC model provides better, safer care for some of our most vulnerable patients, and yet the economic and policy environment is actively working against its survival.
And this brings us to our final question, and it's one that extends far beyond just this one topic. If a system is created that demonstrably improves patient outcomes while saving the whole system money, what is our obligation to support it? It forces us to ask, how should our healthcare system truly reward the innovations that actually work?